Welcome to the August monthly meeting of Physicians for a National Health Program, Western Washington. I'm Sherry Weinberg, and I'm the president of this chapter. We're a chapter of Physicians for a National Health Program, which is very much interested in the idea of Medicare for all. So I'm going to start passing the microphone around, and if everybody would introduce him or herself. I'll go this way.
My name is John Carney. I'm the representative from Students for a National Health Program at the University of Washington, and also a research coordinator at the School of Medicine.
I'm Kathleen Randall. I'm a member of the board, and I'm a retired medical assistant.
Yeah, Dana Iorio. I'm a board member, also an employee at Harborview, nurse practitioner.
Hello, I'm Gary Rendell, Executive Director for Project Access Northwest.
David McClanahan, retired physician. I'm the coordinator since the chapter started in 2005.
I'm Marty Schmidt. I'm a former board member and an employment lawyer.
I'm Jose Mayorga. I'm a CCM in Harborview Hospital, and we'll let you know more.
I'm Kim Lundgreen, Vietnamese CCM at Harborview Medical Center.
I'm Salma Musa, and I'm Somali-speaking caseworker, Cultural Mediator.
Hello, my name is Lea Ann Miyagawa, and I'm the nurse manager of the Community House Calls program, which is interpreter services at Harborview Medical Center.
I think it's really wonderful that we have a chance to hear from community house calls at Harborview. And I get the magazine that comes out of UW Medicine every month or two. And there was an article about community house calls there that really turned me on because it reminded me exactly an experience I had in Cuba in 2004 where we went to the community health centers, and they had people exactly like you have to help mediate problems that the patients who are supposed to be coming to the clinics might have, and might be a reason they didn't show up. So they have community workers who go into the homes of these folks and find out, are they too sick to come to the clinic? Was it a transportation problem, or do they just need a little re-education about how important their health is? So I think this program is very similar in how it reaches out to the community, and it would just be amazing if your service was available to everybody in this country, because I would guess that at least 30% of people in the United States would need it and could benefit from it. So, I'll turn this over to Lea Ann.
Okay. Can you all hear me?
Yes.
So thank you for having us tonight. As David said, my name is Lea Ann Miyagawa, and while it says on the flyer that I'm the director, I am not the director. I'm the nurse manager, and I have been at Harborview for just about 3.5 years, been a nurse for over 35 years, and the bulk of my career has been in public health. And so what we plan to do tonight is to talk to you. I'm going to give just kind of an overview of the program, and then we have 3 out of the 8 team members here so that you can hear from them. They're each going to present a case study, and then that illustrates some of the pillars of service that we provide to patients at Harborview. So we're all employees of Harborview, and as many of you may or may not know, so Harborview is owned by King County. It is governed by a board of trustees, and it is operated by the University of Washington. And it is a level 1 trauma center that provides service to Washington, Alaska, Idaho, Montana. And the mission is really to serve the most vulnerable populations, and that includes the limited English proficient populations. And just for your information, so for fiscal year 2017, 19% of our outpatient visits were to limited English proficient and deaf and hard of hearing. And we had 11% of our inpatients that were limited English proficient and deaf and hard of hearing, and then 14% of our emergency department admits. So we have a fairly robust interpreter services department at Harborview, unlike many hospitals in King County. So we have over 35 interpreters that are employees of Harborview. And then we also have 2 programs under the umbrella. That is Community House Calls, which we'll talk to you about tonight, and then the other one is EthnoMed. And very briefly, I want to just put a shout out to EthnoMed. So this is a web-based resource to providers who are looking to enhance their care of immigrants and refugees, that really makes information available around culture, around language, health, and illness. To providers that may have different healing and belief practices than the patients that they're serving. And it is at EthnoMed, so it's ETHNO med, MED.org. And I encourage you to look at that. It's a really good resource for providers. But we're really here to talk about community house calls, and that's what we are here to talk with you about. So this did start as a Robert Wood Johnson grant in 1994. David mentioned Ellie Graham. Ellie Graham was a co-PI along with Carrie Jackson. And the intent was to, with the term community house calls, was really to go out into the community and learn from the community members and the leaders for the communities that we were serving at Harborview. And so, and it was focused on outpatient services. And after 2 years, Harborview said, this is so much a part of our mission that we're just going to incorporate this into our services. And so all of us are now employees of Harborview, and nobody's on soft money. And the mission of our program is really to contribute to the health of immigrants and refugee patients and families through partnerships that promote culturally humble and sensitive care. So the team, and we have 3 of them here, bridge between the immigrant patients and their families and the healthcare teams. And then the other thing that we also do is we bridge between Harborview and the communities. So we really hold Harborview accountable. If we have folks from the community say, this went really well, we let Harborview know that administratively. If there's issues that certain community members have that were problematic, then we also let administration know about that so that we can make changes around how we serve immigrant populations. So, and in fact, the team is also responsible for providing service to the communities. So whether that could be that they're on a health board, that could be that they provide care and time for support groups or health forums. And that's an integral part because it really gives us a pulse on what the communities are saying and doing and what their needs are. We also have the ability to do home visits, where we have the privilege to be able to go out into patients' homes and to see what their environment is like. And it also gives patients the opportunity to be able to see healthcare providers and people from the healthcare team in their own environment. So our team consists of 8 folks, and they're amazing. 2 of the people have been with the program since 1994. And I'm going to just show you the team here. So we represent the Spanish-speaking community, the Ethiopian Amharic, the Cambodian Khmer community, the Somali community, and the Vietnamese community. All of the team are bilingual and biculturally congruent with the patients and the families that they see, and that's pretty unique. And we have, at Harborview, have really held that as a constant. There's other places that have navigators, and it could be a Somali navigator seeing a Spanish speaker or Iraqi, but at Harborview we make that bilingual, biculturally congruent important. And We only see people that are patients at Harborview, but they can be in the inpatient or the outpatient setting. And we also will do cultural consultations for anyone in the UW Medicine umbrella, so that could be other hospitals and other neighborhood clinics. As I mentioned in the beginning of the program, the majority of the referrals came from outpatient settings, but in the last 5 years, we've seen an increase in the referrals that we get from inpatient healthcare providers and healthcare teams. And that has been around palliative care, within a cultural context, oncology, and also our trauma units, of which there are 4. In addition, the past 3 years, we really looked at data around chronic disease, specifically diabetes, and what we looked at was hemoglobin A1C, which is really a determinant of blood sugar control. And those folks at Harborview that were English speaking that had A1Cs above 9 were 18.7%, but we had 2 other communities that exceeded those, and that was the Somali community at 26.4% and the Spanish-speaking community that came in at 24.1. So we were able to have 2 folks, and Salma is one that is working in her community solely around self-management of diabetes, and then also a Spanish speaker that has diabetes patients as well. So you might wonder, we have interpreters and we have caseworker cultural mediators, and how does a provider or a healthcare team decide which to use? If you've worked with interpreters before, you know as providers or members of healthcare teams that the interpreter is dependent on you as the member of the healthcare team. When you're talking to the patient, the interpreter then interprets and then to the patient and then back to the provider. And there isn't independence around their conversations. The caseworker cultural mediators here have much independence. They meet independently with patients and families. And they also, we have 6 major pillars that we do, and that is navigation, that's advocacy, that's mediation, that's education for reinforcing to the patients as well as the healthcare team around cultural issues, its interpretation, and its case management. So that it's really the complex patients that are limited English proficient that are the referrals that this team gets. And so what we thought we would do is, one last thing too. All of these folks document in the electronic health record. Interpreters do not document, so that the healthcare team can then see what the caseworker cultural mediators have done. So what we thought we would do to illustrate this is to have each Salma and Kim and Jose have put together a case study to really illustrate a couple of we have the 6 pillars, and they each took 2 of them, and so they'll give you a little case presentation to let you know how it is that they provided service for that patient.
So my name is Salma, and I'm a Somali-speaking cultural mediator at Harborview. I've been working at Harborview for over 12 years, and as a cultural mediator, I'm a health promoter, a health coach, and a health navigator. My role includes a lot of navigation and education, and at the same time, most of my caseload is just for patients who are diabetic, type 2 diabetes. I'll share with you a case study, and I'll go and illustrate the navigation and the education piece, and my colleagues are going to talk about the rest. So I'll share with you a case study. A patient of mine, she's a 75-year-old female Somali with diabetes type 2. She came to the US in 2004. Her initial diabetes onset was in 2005, and her A1C at that time was 9.8. Patient is illiterate, and she attributes her diabetes to stress. Can you imagine somebody coming from a different country, the adjustment, there's a lot of stress. She lives alone. Most of our family members are back in Somalia. She has difficulty accessing complex healthcare system in the US. The healthcare system in Somalia is totally different. So in Somalia, people would go for acute illnesses, let's say malaria, typhoid. You go for an infection, you're given antibiotics, and you're out there. So this patient had many no-shows and cancellations because she thought that there were too many unnecessary appointments for her to just go to the doctor, get out of there, just when she needed it. Maybe, in 10 years, maybe 2 times, just as, even how she was feeling. And with the diabetes, she didn't feel anything. And so it was difficult to explain to her that, coming to appointments, so she would no-show or cancel. And then the other issue she had was, another barrier was transportation. She didn't know how to get access. She could not read and write. She did not go to, just accessing the system, the transportation system here from going from, let's say, Buren to Harborview is a big issue for her. There was lack of trust, and the providers are totally, there's barrier of language, communication, and with diabetes, she wasn't monitoring her diabetes, and she wasn't checking. She was tired of poking. She's like, well, she didn't understand why should she be checking every day. She was taking her medications as needed, just like Tylenol. She gave her some like metformin. She feels like her blood sugar. She would feel symptoms like if she had thirst or whatever, she would take her medication. But if she doesn't have any symptoms, she wouldn't take anything. So she was confused about what foods raise blood sugar levels, what foods to eat. She spent most of the day alone, and she wasn't physically active. And given our weather here in Seattle, it's always raining and it's cold compared to back in Africa where with sunlight and you go visit your neighbor and just walk and she knew everybody. But here she was like kind of alone and she didn't want to go out. She was always indoors. So the barriers that she faced, it took me a while to start to get to know her and to introduce my role and gain the trust. So she is in our program we use MI interviewing. So I used open-ended questions to get to engage more with her. So the biggest barrier we had with the provider was that most of my patients are Muslims, and my patient was practicing fasting. So in Islam we have fasting. It's the fourth pillar of Islam. I don't know if you guys have had Ramadan. We fast from sunrise to sunset, and we just had our Ramadan, and it was like 18 hours of fasting. And so so in Islam, people who are sick, like pregnant women, people that are old, people who, they're exempted from fasting. But some of our patients, especially like my patient, she knows, but she wanted to get the rewards of fasting. So when I sat down with her, I told her, you're exempted, you're sick, but you know what she told me? She told me, look, I'm going to tell you this. This world is just few days, but the hereafter is for eternal life. It's an eternal life. So you want me to give out this for that long, eternal life? So, but she couldn't share that with her provider, so she would not tell the provider that she was fasting. So on the days she would fast, she would not take her insulin because there's nothing to eat or drink. She was not taking her medication, and she would break her fast with a big meal. After 18 hours of not fasting, you break your fast with all this, fried foods. You have different types of cultural foods that you eat that are not so good for diabetics. So I started engaging with her, and I, because I speak her language, I, told her, everything you say, I'm like, she trusted me, and she thought that, because we're in the same place, I could understand her better. And so I used MI, and I used, through Ethnomed, we used diagrams, we used pictures. I tried to explain to her about diabetes as a chronic disease, was, about how things work. I tried to, show pictures. I assisted her to try and navigate the system. I tried to arrange transportation for her. I made sure that she came to appointments. I would remind her of her appointments and say, listen, tomorrow is the appointment. The taxi is going to come. The appointment is 2 o'clock. The taxi is going to be there at 1 o'clock. So be ready. And then the follow-up appointment so that she would not miss appointments. And so she started getting, the more she came, the more she learned, the more she started engaging with her provider, and she shared, and she felt it was okay to say that she's fasting. And so once she opened up, and I told her, your provider is not going to eat you. She's not going to harm you. Just be honest. And we work here as a team. So I introduced her to the dietitian, the pharmacy, and with the dietitian, we didn't have dietitians back in Somalia. So she's like, I've been eating this meat, or for 7 years I've been eating rice and a big amount of rice, and you're telling me to eat like a 2-year-old portion of rice? Because we would say, reduce your carb portion. And so it's hard for all those years eating like that and saying, no, you can't eat more vegetables. And so I tried to help her, work with her around the dietitian, and I said the dietitian's role is she's here to help you. I made her an appointment with the pharmacy, and I said the pharmacy, educated her on how the medications work, not on an as-needed basis, but on a daily basis. And so she started, taking her medicine. We walked around. The provider came with a care plan of reducing her insulin when she's going to start her fast. They reduced her dose to half so that she could help her. And so she started taking her medications on a daily basis, and she did wonderful. Her A1C reduced from 9.8 to 7. She joined this exercise. She lives in a senior housing, so I went with her. Me and Lea Ann did a home visit. We found out there's an exercise program every Tuesday for the seniors. So she joined the program, and she does weekly exercise. And they gave her a small pea patch, because she used to garden in Somalia. So in summertime she does plants. She has her small garden where she has her her vegetables, and she makes sure she eats those vegetables. And so thank you for having us, and I appreciate you welcoming us here. Now I'm going to give my colleague will take over.
Hi, this is Kim. You hear me, right? The Vietnamese caseworker, cultural mediator at Harborview Medical Center. I have been with this program since 1997. I work mostly with the Vietnamese patient populations. Today, I would like to present a case that illustrates case management and interpretation. This is 73 years old, female Vietnamese-speaking patient who had a routine mammogram. It shows some distortion on her left breast. She was referred for biopsy. It revealed invasive pleomorphic lobular carcinoma. She then referred for MRI. After all of the procedure, she then was referred to breast cancer at Seattle Cancer Care Alliance. She was seen by medical oncology, surgical oncology, and radiation doctors. In 2017, she underwent a lumpectomy. After surgery, she went on to receive radiation therapy for 6 weeks and received chemo for 6 months. She has been doing really well. She didn't have any side effects. She now has to follow up with her medical oncology doctor at SCCA in every 3 months, and her PCB at Harborview Medical Center. I became her case manager when I got a referral from her PCP. I met with her provider prior to her follow-up appointment. He informed me of her ultrasound biopsy results. I was a patient at her appointment, and it was a big surprise to her when she received this bad news from her doctor. She broke out crying and said that she didn't know what to do. She is illiterate, she is widowed, and lives alone by herself in a subsidized housing apartment. Her provider spent a long time discussing her diagnosis and trying to give her a positive outlook. He assured her about quality of care at SCCA and assured her that he would follow along closely. He told her that he would refer her to the community house home program, where there is a Vietnamese-speaking caseworker who would be working with her to go through this difficult time. He then introduced me to this patient. I introduced myself and role. I assured her that she would have my support and assistance. She felt better. As a caseworker, I coordinate all of her care and follow-up care. I try to be with her at her clinic visits, and I arrange transportation for her and go with her to the first field visit at SCCA so she knows where to go. At this visit, SCCA provides interpreter, and I provide continuity with case management, listening to what was said at appointments, coordinating any transportation and other appointments needs. I also provide interpretation as needed. She stated that she felt better to have me as a consistent interpreter and case manager that understood her story and provide feedback to healthcare team. Continued interpretation is very important, especially for those with chronic illness. Having someone who speaks her language, assure medical information, and options for therapy are clearly communicated and understood by patients. When family members are used, they may filter information or information is not clearly communicated. Another important point regarding interpretation is Google Translator. I mean, interpreting and translating by Google Translating. There are many examples of inaccurate translation by using Google app, and it should not replace qualified interpreter or translator. At her last visit with her primary care provider, she gave us a very big smile and said that without this kind of support from her provider and me, she cannot be like what she is now. Thank you for listening to our story. Now I want to introduce my co-worker, Jose Mayorga.
Spanish, case manager, cultural mediator, and medical interpreter. I am a medical interpreter since late '93 in Harborview, and served to full practice in CCM for the last 7 years. My scope of work was with oncology, hematology, palliative care clinics, and with the patients in the intensive care units in the hospital. Usually what I do is I get the census of the hospital in the morning. I look for all the Spanish-speaking people listed as Spanish-speaking, some that they sound that they could be also Spanish-speaking, and I go select them and visit them. Out of the list, then I visit the ones in the ICU units, and my first contact is to make an assessment of the needs of the patient and the families. I work with the nurses working with the patient, with the family. We could have it right now, maybe understand they're thinking any patient younger than 30 years old will speak English and his parents or her parents won't. So there's always a lack of communication. It's a problem that arises all the time there, and that's part of what we do every day. I do, like Lea Ann mentioned, I work with EthnoMed. We do, sometimes we do translation of documents. We try to find out how well they will really go into the community. So we bring members of the community. We show them what we have. We show them the pictures of, we want to make sure that they are not culturally offensive for them, and also that they will really explain the intention that we have to do with that. I'm going to try to condense my intervention to mediation and advocacy. I'm going to use one of my patients to illustrate how I do the work. One of the things that I preach and try to practice all the time is I want to have a pre-conference with the providers before I get into the room. I want to know what intentions they have, what they need, and how can I help them to make the things easier. In this case, let me give you a little bit of history about the patient. This is a 70-year-old male patient from Argentina who was diagnosed with Hodgkin lymphoma. I met him when I was called to assist the oncology team to visit him while he was in the hospital. So in the pre-conference, I was told that he wasn't helping to his treatment, that he was disengaged and hostile most of the time. Also another concern was that he was underweight and not eating well. So the team left, I stayed with the patient, and I started to talk with him. We started to talk about his country and the things that he likes and all those things. And after a few minutes, we have some kind of report. So I asked him, okay, how can I help you to be able to endure the chemo treatment that you are going to have, and how you feel better here in the hospital? So he told me, well, look, what I'm going to tell you is this. Number one, nobody tells me what they are doing with me. They bring medicines, they give me the medicine, but nobody tells me what the medicine for. Or they talk to me, but I don't know why they talk to me. The little time that I have a chance to fall asleep, they come and they wake me up and take vital signs home. You know, it's not a good life for me. You know, so I told him, okay, let's talk about how can we do to help you? He complained that the communication using a telephone interpreter, it was very difficult. We found that in the units, patient was sedated or sick is going to have very difficult time to understand what's going on. We know that we have a really seasoned and expert team of interpreters in Harborview, so the patient will feel the difference immediately, what's going on, and they stop to complain. One of the things that I hear from him, and it was important to communicate with him, is that he's from Argentina. Being from Argentina, they are influenced by the immigrants from the Second World War that they went to Argentina. You know, more Italian, more German. You know, so they are very open to talk and say the things in the way that they see the things. So one of the things that caught my attention is when they asked him, "How are you doing?" He responded in Spanish, "Podrido." Podrido, if you do the literal translation, you say, "I'm rotten." The appropriate translation that I would do is, "I'm very sick." That's the way, you know, that I will do it. Because of the difficulty of communication with the patient, he was labeled as difficult to get along and even sometimes offensive. So I asked him, what can we do? Are anything that you would like me to ask for? So he says, the first thing that I have the problem is I get scrambled eggs every morning, and I hate that. I don't like them. We don't need those things. Okay, well, let's see what else. And, you know, in the list of the complaints that he had, I asked him, give me some route to help you. You know, I want better food. I want a fat, juicy hamburger. I want people to come with a telephone interpreter. They're going to give me medicines. I want to know what medicines they're going to give me. If they need blood, I want to know. If they're going to do something, I want to know. And if it's a change of the plan of care or it's something that's critical in the medical update, I want an internal interpreter to help me to understand what's going on. With the information, I called the kitchen, the food service in the hospital. I told them, okay, I have a patient here that's getting the food all the time, and you know, scrambled eggs every morning for the last week or week and a half. They told me there is nothing that we can do because he is in a fixed tray. Fixed tray means a very condensed diet, very limited diet, and in my mind, well, every time I go to the oncology clinic, the first thing that I hear from the doctor is, eat all that you can, that please you, and don't count the calories, just get busy and eat all that you can. The food service department reported, okay, we won't be able to change it just because you tell us. You need to get the nurse involved, you need to get the attending doctor, and say, okay, well, we're good. I went, talked to the attending doctor and the medical team, explained to her, she was surprised at how come he was in a fixed diet. Fixed tray, it doesn't make any sense. So that day he got his first juicy hamburger pie. And I was very, very pleased. We started to talk with him, work with him. Pretty soon he started to develop a better relationship with the hospital team. He was transferred to a nursing home. We worked with him to go to a nursing home because the chemotherapy program for him had the problem that he was homeless. So we have to find a place for him to stay, being able to go back and forward to the chemo infusions for the treatment that he needed. I got involved in that part too. We start to I said to make sure that he will get the transportation that he needed. I will follow him and all the follow-up visits with the clinics to make sure that he will get what he needed. For the first couple of weeks, I visited him almost daily, just to check on him, to see how he was doing, if there's anything that I could help. A week later, everyone was saying, how nice is this guy, how well he's doing. Well, if you pay attention, you listen to the person, it's going to be easier. The other thing is, his son is a very active person. He told me, you know, I'm going to do whatever I can do for my father, but also he's homeless, so he's living in his van. But we started a conversation. I started to talk to him. I told him what I feel. I was listening from his father, what I knew about the Argentinians and how they do things. So he came on board immediately. He started to come to the family conference that we needed. There was everybody working in the plan of care for him. He is the only patient that I know in 23 years that gained 20 kilograms doing chemotherapy. He was so strong and so happy he wanted to teach the attending doctor how to tango. That's the national dance in Argentina. He's doing really well. He got involved with the people in the nursing home and he became the star there too. He exercises every day. He goes, they use different machines. He is the one who wheels the other patients to the activities. And right now we are working with, I think that he's already very close to go to New Jersey, where he has a nephew who owns a little farm there, and he would be living with him. But it's pretty much, you know, sometimes it takes to talk to the team, to explain to the team the advantage, as Lea Ann said at the beginning. We are part of the medical team, and we have voice, and we can do things that other people don't do. So that's a summary of what we do. We do other things, but that would be at least to explain the pillars that we have. Are we anything that you want to do, or we are open for questions and answers?
So I have a question about Harborview has a lot of people who, you know, are not salvageable. Do you get involved with, you know, decisions to let somebody go or organ transplant, that kind of thing? I know a lot of communities, it's a very difficult decision to make.
Well, because I am involved with the oncology, hematology clinic, palliative care, I have a high number of patients that they are going to die while I'm working with them. Usually, the most common thing is we work with the patient, and we are with the patient, and we listen to the patient. Patient will know. They know when is the time for them to go. Usually, what we do, we are involved with the comfort care. That's one of the things that we offer all the time. We do home visits with the physicians, and we refer them to a hospice program. In the time I've been there, only once a patient asked for support to go and to get assistance to end his life. But it was kind of a moment of time. Really, most of the patients that I work with, they know what's going on. They support that we give to them, allow them to be at peace and take decisions. Pretty much the decision is when I want to stop anything that's going to be invasive, or when I'm going to stop something that is aimed to cure and it's not working. You know, we always talk about balance between what's going to improve the quality of life of the patient and what is not. And we make sure that the patient understands clearly what's going on. Sometimes we find patients that they tell us, I don't want my family to know anything. There are families that they come, we don't want the patient to know anything. You know, he's going to learn something, he's going to die faster. I think most of the time we come to a reasonable outcome where everybody is happy at the end.
I just want to add about organ donation. So if there are cultural issues around organ donation, we strongly advocate for the families around that. I was just involved in a case last month where the family was absolutely opposed to an autopsy or any organ donation. So we can intersect before the folks, I can't remember their names, the organ donation folks that come and talk to the family, and we will say for religious or cultural reasons, this is not a family to approach because that's going to be offensive and they're going to oppose anyway. So we do that. And also, any family that the CCMs are involved with that then end up dying and there is the topic of donation, they never get involved with that. So there's another interpreter that needs to interpret around that information so there isn't this perceived conflict of interest around they were, they had relationships, they were advocating, and now all of a sudden you're talking about organ donation. So we separate that.
Just to add on that little piece about death for Somali patients. So because of Islam, we believe that this is just a transition and this life after this life. So the organ donor thing is a little bit tricky because we preserve our body, the body, we believe that, the person has feelings, it's just the soul is separated from the body. But the soul, is going to end up, it's really important that, if you don't get anything out. I don't know, I'm not like, I don't have any expertise in the religion very well to talk about that, but I know our patients are a bit sensitive to that. And also, when you have like an accident or a sudden death, it's hard for the family, while they're still grieving and everything, when it goes too quick. Like last time we had a boy who drowned, I think it was like in Ramadan, end of Ramadan, young 19-year-old, but it was so hard for the mom, he's here, then everything, okay, it's done, he's dying, family conferences, in a few hours, everything Shalina is dying, and then organ donors, can we, it's kind of hard, it was kind of, and also the trust, it's like, are they doing everything? Are they giving us 100% care here? Or just they're doing this because they're doing this and they just want this, our loved one to die, that they can donate the organ to somebody else. So it's kind of tricky, it's hard, and the way Lea Ann said, sometimes we don't want, conflict of interest. You try to engage with this family and then, you see the organ donors saying that, the organizer saying that, there's somebody representing them and saying, can you interpret for me?
I belonged to the League of Women Voters a few years ago, and I remember being at one of their presentations, their forums, and one of the speakers, she was from the Somalia area, and she was talking about being here. She felt isolated within her own community because she also had to interpret and help people from other communities, and so she couldn't befriend or advocate adequately for one, and so if she had a friendship with somebody from another community, so it was sort of difficult. And I'm wondering if you experienced some of that either in the Southeast Asian cultures or in your experience here with our communities. I know that we have a number of people from different areas, like Ethiopia and Somalia, and some of the others have shared language, some shared language.
So are you asking if there is, if sometimes patients feel like they maybe don't want some of these folks involved with their care because it's such a close-knit community and they're concerned with confidentiality and those kinds of things?
Yeah. Or maybe just build up a suspicion of.
Okay, so the worst, I'll give you an example of maybe when it's mental health. So with mental health, there's stigma, or if patients have like HIV in a small community and they really don't want to share that. So there's a time like for being, there's a patient that, okay, the cases that I was doing in the Madison Clinic, Harborview, and in the beginning, like the patients would say, I don't want to see in-person interpreter, or they don't want somebody, a CCN I would prefer the phone. So maybe providers would, it's a good thing, maybe the providers before calling an in-person interpreter, maybe to use it on the phone if it's comfortable for them on the phone so that they're not labeled. Maybe they might think, oh, okay, if I interpret it for them and then I see them in the mosque, let's say, they might, oh, she's gonna talk about my issue. And we, as the interpreters, also have the, we have to keep confidentiality and, code of ethics, and, whatever is in there, we don't share with our families. We don't. But do they feel like that? It's hard, to say, to make them feel comfortable. So we try the best. If we, in the beginning, the provider should talk with them and say, would you prefer a phone? Because if it's a small community, we know one another, so that they don't even get to see. But what happened with my cases that I was helping in the Madison clinic is I got to know one of them, and I said, everything that is said is staying here, and believe me, nothing leaves here without your consent. And so we built a good relationship, and I worked with her, and she was so happy later on. So she would only choose me, so she didn't want anybody else. But once the trust comes in, it's about trust, shared decision making. Even with the providers, even with the diabetes program that we have, when you have a provider, sharing, decisions and say, what do you think? This is what I want to do. This is what the plan is. This is, making the patient involved, and then asking questions. And also we use the teach back sometimes method to see whether they understand. If you want to see if they understand, you say, tell me in your own words, what do you think? And sometimes I have some patients where sometimes the provider will say something and the patient is like, oh my goodness, don't even tell. I don't think, like, they'll roll there, like, what are they talking about? They don't agree. So sometimes in such a situation I say, you know what, be honest, tell them what you feel. It's not about being right or wrong. It's about discussion and sharing. And then you come up with the outcome. Both of you, will benefit. But if it's one-sided, who is it going to, whatever the provider is trying to do is to help you get better. And when there's transparency, I think communication gets clearer, and the technique and the style of communication is really important.
Thank you.
I would like to add to that. Like Salma just said, building trust is very important. I have a case that a patient, she just got she was diagnosed with cancer, and she really need, lots of help. So her provider told the PCC there that she should let me know, refer to my program so I can help her to go from here to there, to help her, to support her. I know her, she knows me because we go to the same temple. And then she said, no, don't refer me to Kim, because, I see her at the temple all the time, and I don't want that going around at a temple. So the PCC told her, say, no, Kim is working here, and she knows what to do, and especially she with this program, she helped the patient, and that will not go out to the public, to the community, so don't worry about that. So the patient can hesitate to accept that refer, So I met with her, I talked to her, and then we built a relationship, and she trusts me, and we are together, from that time until now. She always wants me to be with her whenever she come back to see her provider at the hospital. So that's something that building trust, when they believe you, they trust you, and everything will go on very well.
Thank you.
Just a couple of things to add. Most of us, we are involved in the community. So we belong to the community health boards in our communities. We are well known, and every time I have a new patient, I explain to them the confidentiality of the situation. And in my line, I know that I need to go a little bit further because we Latinos, we don't trust many things, but they don't want to come to the hospital because they can be detained there and deported. All these things are critical for them, but I explain to them, okay, look, I'm your interpreter, I'm abide to the same rules that the doctor has. I can't disclose anything that I interpret here or I talk here. I won't be able to do that. If the judge called me and asked me to talk about your case, I have to have a written permission from you to do it. Otherwise, I have the privilege to say, Your Honor, I refuse to do any reports because I don't have the written permission of the patient. That type of things build the trust, and we are continually seeing, more patients that in the EPIC or ORCA note says, I prefer this interpreter. But the preferred part is not preferred because I like the person, it's because I trust the interpreter.
Are there ever any times when your own age is a factor, possibly an impediment to establishing trust? And I wondered how that might go in different communities, whether the program looks at the ages of the cultural mediators and the interpreters as a factor in staffing and appropriateness in terms of the community relationships.
Since I've been at Harborview, I have not had any requests around age. We do have requests around gender. But in terms of our interpreters, they really span the ages from, 30 to older. And in our team, I'm not really sure how old everybody is. So I think that that's never been an issue since I've been there. I think, Kim, you've been there the longest. Has that been an issue? I think, I think you can really see from these folks that establishing trusting relationships is really what this is all about, and their sensitivity and their awareness about that, I think, is really important, and age has not seemed to be a factor.
Most of our cultures, we see aged people of wisdom, and the trust, as you've shown your experience and they see you, it's the opposite. It's more trust, it's more, okay, I want you to help me. Sometimes you got to be very careful because they will ask, what should I do? That's part of the, but all our cultures, as far as I know, I never hear somebody says, I don't want that. At one point in time, I was the only licensed interpreters to go to the gynecology clinic and interpret them because at the time that's what we had to do. But pretty much there's respect there in the way that we do things. It doesn't seem to come across in those ways.
And I can attest that patients do trust Jose quite a bit. Young, older, doesn't matter. But my question is, as a provider, if, like you guys brought up, there's a high no-show rate for especially follow-up appointments. So when I have somebody that I'm really concerned about and they don't show up, they're a no-show, is there a way, there's got to be a way I can get a hold of community house calls and ask if they will make a home visit to the patient? Can you do that through EPIC?
I'm pausing because the first thing that I did when I came here to Harborview 3.5 years ago was talk to EPIC and say, we are still on a paper referral, you're kidding. Can we not get on EPIC? And I won't bore you with the details, but we are not on EPIC yet. And so it's the old-fashioned way. It is a phone call to me to say, or an in-basket about your patient to me. And if the caseworker cultural mediator knows this patient and there's an established relationship, we will do a home visit, no problem. Sometimes it's a little difficult to do a cold home visit because you want to have a relationship with the patient so they can refuse if they want for you to come out to the home. But oftentimes I'll go to these folks and they will know why the patient didn't show up, or the patient has already called them, those kinds of things. But absolutely, we can do a home visit.
Can I just ask?
Yeah.
I just want to add what tips that will help you is when you see a patient before you end, you do a summary and you say, I'd like to see you maybe in 2 months or a month, and we follow up if it's blood work or in that condition, or try this medicine and see how it works, and then I'd like to see so that you can give me an input of the medicine helped or not. When you fill them in like that, they know, okay, this is why I'm coming back, and they'll keep that appointment. And if not, maybe the other thing you would do is maybe ask an interpreter, or maybe just request for a telephone call, and then an interpreter or a CCM or whoever can help you can call with you, and you can ask why, and maybe they forgot about it, and the reason, and then say, would you want to reschedule? And I think that would help.
And yet, I think of a case that we had where we did a home visit for this exact reason. She wasn't showing up, stage 4 esophageal cancer, needed to get into treatment. And so we went out to the home and we listened to their story. And this woman had 8 children. Her husband was older. The thought of her having to go through chemo and being incapacitated because she was the only person that navigated for her children. She got them up. She paid the rent. She went grocery shopping. After that, then she'd go work from 4 to 1 a.m. Cleaning Amazon facilities in Kent. So we just sat and listened, and we realized that, wow, to take her out of this, out of her environment was we were humbled by that. So then, we went back and we documented, talked to the staff, and just shared that story because no one knew how much of a hub she was to that family. And there was an acceptance around, we'll see you when we see you back.
When you've established this trust, do you find that some of these patients are calling you for advice, even medical advice?
Yeah, they sometimes when they're stuck and when they trust you more than the provider, they'll ask you that, and that's why I always say about transparency. I'm not the provider, I'm not the expert, but filling them in and saying it is important to say to trust your doctor and to let them know what you feel and what are the barriers. So if there's cultural barriers that I need to educate the provider, I'll input the provider. But if it's the patient and lack of trust, it's about engaging. It's about building relationship and establishing that partnership. And once they see that you're genuinely there, they read expressions. It's not about the language. They can tell when you look them in the eye and welcome them, and they feel there's energy that they can feel that you really care about them. So when you look in their eye and you show on this, body contact and asking questions, how do you feel, you can tell. It's not about the language sometimes. They can look, they know. And in my culture sometimes they use their language, sometimes we are praying for you. Some of them are so concerned that they love their provider so much that they say that, he's such a good provider. God bless them. And sometimes, because we believe that if you don't believe in this one God, that you might go into, gonna go into a paradise. So they, out of the visit, is like praying for them so hard. They go to paradise with us, They genuinely feel like, I wish I would do something. This provider is trying to help me get better. And I want to help them in the hereafter so that they can be with me forever in paradise. So it's how you communicate, the style, how you deal with them. They know, I have, and everybody's different. As interpreters, we go everywhere. We see everybody's style is different. The providers are not the same. Human beings, we are not the same. There's a saying in Somali, like the fingers are different. This side, my fingers are not the same size. And we like that. Human beings are not the same too. We have different personalities. But, if you're in healthcare and you show empathy, you show that you care, they will open up.
Yes, the question comes all the time.
What would you do if you were me? I can imagine you hear that a lot.
Well, I'm going to tell you what I do. Basically, when I have the question there, I have notes in my mind of what I hear from the doctor. So I say, okay, you need to listen to what the doctor told you. And the doctor mentioned a few things that are important. We need to listen to them. It was one of the clinics that I work most of the time. I will make a conference call. If I can get the provider there, or I make an appointment to talk the three of us, to remind the patient what's going on. I don't take the role of the doctor. even though I've been asked to get my license and practice there. I wouldn't do that. But it's a continuous question, you know, but it also is an education, like Salma says, to the providers. A few years ago, I would say something to one of the doctors, he would look at me and say, okay, what school did you go? Did you go to the same school of medicine that I did? And it was difficult to get across of that. But today, I can see the medical director going to a family conference, and before he used to tell me, you know what, I'm a doctor here, I've been a doctor for 40 years, I'm not going to tell the patient what to do. I'm going to give options and the patient has to choose what they want to do. From that, I hear a doctor, medical director saying, well, if you would be my mother, I will do this. You know, and that changed completely the plan of care. When I'm listening to you, you will take care of your mother in the way that you're taking care of me. I'm okay, I'm here. So it's education in both ends, you know. But yes, we will get the question, but we know that we don't need to get involved in giving advice, but we can communicate with people and get them involved. And some of my patients, I refer them, look to the summary that you got when we finish the appointment, so they can, you know, start from there. And some patients, they will need 2 or 3 times before they really get it and know what they're supposed to do. So it's part of what we do at work, and we have to remind them, you know, how to work. But I think that the flexibility that we have is that we can contact the provider, talk to the provider, explain what's going on. Sometimes it's difficult to get in a conference call, but I can send a message through the system, I can email, I can page the doctor, explain, okay, this is the situation, what you want me to do. Is it something that you want me to convey directly to the patient, or something that you want to get involved and we have a conference call? I follow what the doctor is going to ask me to do, and we have results because of that.
Are you also involved with children's? No, just you don't.
It depends, you know, but especially we have kids in most of the time in the burn unit.
Oh, yeah.
So those are the ones, and yes, we get deeply involved with them. Sometimes because of the magnitude of the situation, but those are the children that we, in my case, I think Leticia has.
I think she was asking if we were involved at Children's Hospital.
Oh,
And we're not.
Children's Hospital.
Thank you, I was.
Yeah.
Okay, that too, but we have limitations there, because when I approach children, when I talk with them, the person who's supposed to have the same title as I have, I will go there and talk to them and tell you, you know, all that you need to talk with a social worker. I can't do what you do in Harborview. But we try to hand out the patient and make sure that the patient and the family gets the support that they need.
Continuity.
Not easy,
Right.
Sometimes we do.
But Children's has their own navigation program. It looks a little different, so.
Are you involved in training interpreters?
Through the Harborview system?
No. We are not involved in training interpreters. That's kind of a separate, I have a colleague that oversees the interpreters at Harborview, and there's a separate training than the caseworker cultural mediators go through.
Most of the interpreters in Harborview, in our team, they have at least 5-6 years of experience working in Harborview. I'm doing a presentation pretty soon to another group, and we found that at the years of experience of the group of interpreters in Harborview adds over 450 years of experience, professional experience in the field. So pretty much we are the elite team in the Puget Sound. Many colleagues, they want to work with us, even sometimes they have to take a column pay to come to Harborview.
Wondering if I could ask, first, thanks for coming and speaking with us, but I wanted to ask you, So it's interesting that you guys are such a critical link between the patient and all of the services that they're getting. And I think that's interesting in contrasted to a patient who's an English speaker, because they can build rapport with the nurses and the doctor and the technicians and all of the other providers, whereas you guys are almost like the sole conduit through which they get care and they relay their symptoms and disease. So I'm just wondering, how do you guys, you have to build that rapport, so you have to build this trust and get personally involved, and how do you, keep that balance with not becoming too emotionally or personally attached to the patient while still being an advocate for their care and advocate for treatment?
I think that's a tricky question because what we do, we meet every Tuesdays one-on-one with Lea Ann, and we talk about cases. So we try, if the difficult cases, most of the cases that Jose does is end of life. It's really hard sometimes, in a week, maybe 3-4 patients sometimes die, and you already work with them one-on-one. It's hard to let go. Just like how providers, when they lose their patients, it's hard. Maybe you've been a provider for a patient for maybe 20 years, and you knew them for a long time, and they died. So that's a little bit hard. So what we do is we have a provider who comes in to help us with, if it's stress, if it's mindfulness and how to help, if it's if it's reading stuff. We try and talk about things. We meet with a psychiatrist too. She helps us, and it helps when you talk out cases. We talk through the cases. It helps. We do the breathing exercises within ourselves to help. And also when we have difficult cases, we also help each other, brainstorm and think about how we could help each other. It's hard, but also it has the good side. I have patients who, when you help them too much, and when they just see you, they're so happy to see you. They know that you make a difference. Sometimes we go on vacation and we missed you so much. We didn't know you did that so much for us. I didn't even come. I don't want to see the provider. You're not even there, so I'm gonna, postpone my appointments. I didn't want to come in because you're not there. So it's hard to get a balance, but we have to show compassion, and we are humans too. Sometimes you get burned out, and we try and help one another.
Yeah, that's a really great question, and I think as the newest member of this team, I'm in awe by what they do day in and day out, and what they witness and the stories that they hear. And so we really try to, like Salma said, provide support to them. As a nurse supervisor, I meet with each of them and do reflective supervision weekly, and then we meet as a team 3 out of 4 Tuesdays a week for 2 hours. So there is a lot of support that we get from one another to do this really hard work.
And I would actually have the highest number of patients that they die when I'm working with them. But what they said is usually what I do. If the situation is difficult for me to handle, usually I reach out to my supervisor, Martin Pierre-Louis, the director of the program. She's a social worker with a big heart too. I have the chance to go and talk with her too. There are moments that I really need to sit down. Maybe I have to cry for a little bit. That's okay. Well, at the end of the day, when I go home and I know that I did something good for the patient, that is part of what it lights my load. Personal beliefs, the opportunity to debrief with my team. Fortunately, Harborview is beginning to be more in tune that if several teams are involved with the care of a patient that is critically ill or die, especially kids, we have debrief and we participate in all those things. But it's like you call, we have people that they have happy ending stories. We have people that they go and the younger that they are, the more difficult for us to do, But basically, yes, we have a really good team. We can debrief. We help each other and we participate actively in the cases and the needs of the other CCMs to help to alleviate the load.
Well, just want to add a little bit about that, like all of them already said. And I think it's really helpful that we meet every week, except for one second Tuesday that we don't meet. The psychiatrists come over and talk to us, or we have something that we need to let out. So that really, really helpful. And Lea Ann really support us, whenever we have difficult case and we can come to her. Sometimes, I talk and I broke out crying, but that's just natural. But I get a really good support from our supervisor and our director of the program.
I have a question. How did you deal with it? Like, you are a provider, how did you deal with if maybe you have a patient die, or how did you cope with that?
How do I cope with a patient that I've known for many, many years that dies or severely, severe medical problems? Well, probably a similar way that you do, except I might feel responsible that maybe I could have done something better or made a different decision. I was a surgeon, so should I have taken a little bit more here or a little less there? Or, you're always second guessing yourself when something bad happens. And, very, very seldom is it your fault, but occasionally it is. All doctors make mistakes. So we have to live with that and, hopefully move on. I must say, for 25 years, I worked at International District Clinic with, interpreters there, and they were so critical. The doctors and the providers can't do without you. So, and it's really wonderful to hear your personal stories and see you face to face.
Thank you so much for coming. It's really an honor and a pleasure to have you here. So thank you.
Thank you for asking.
Okay. Anybody else have a last question?
If I can ask, I'm involved with clinical research specifically in Kenya around HIV, and I wanted to ask you guys, do you deal with helping consent patients for clinical research or for experimental treatments, and kind of what have been some of the reactions of your patients in the populations you work with? I heard like Argentina, Vietnam, and Somalia. Or I don't know if you have other populations.
Let me answer that first. I have been working with Vietnamese who has HIV. When you talk to them about doing research, they can hesitate to answer you at first, but when they understand that, and then maybe they will work with you.
I've been asked many times to consult, and the thing that I think works really well with research projects is to put money into the grant for focus groups, to really spend some time reaching out to the communities, getting interpreters, having food, getting people together and sort of talk about, this is what we're thinking about, what have you heard about this? There's one about HPV recently that we were consulted on in the East African community. And so, what was that going to be like? What did we think? And then they did a lot of focus groups, and that was very helpful for them, even before they got to the consent part.
This is my passion in things, Culturally speaking, the translation is key. You can't ask an interpreter to go and explain in the Gulf what it's all about of the study that you're going to do. Saying that, I think if I have to tip my hat, I will do it for the Madison Clinic in Harborview. So they do the HIV. Because I think in my observation is the clinic has most adherence to the plan of care. Because when you get into the clinic, you have to have a diagnosis, you have to have an education with a patient educator, you have a pharmacist that talks to you. Before that, you have the visit with the provider refers you to all these people. You get to the point that you meet with the pharmacist has something like this, with all the pills there, and say, okay, you're going to have this, they look like this. These are the side effects, and it is a complete education. Finally, when the patient agrees to the treatment and knows what's going to happen if they drop the treatment or they are not in compliance, they go back to the provider, and then he prescribes the treatment. And most of the situations that I involve with patients that they are asked to be involved in the study of the case is they want to know what is going to be, what is the results of that, how it's going to be applied. Number two, how private all the data, all the information is going to be, how it's going to be used. And honestly, if I will do it, I will have a special visit with the patient and explain what was the study about. Because most of the patients that I work with, they refuse to do it because they say it's too much. I can't, you got 4 or 5 pages with all the justifications of the study there. I don't want to do it. I don't understand what's going on. And I don't want to tell the patient that this is going to be good, because if I said that, he's going to sign or she's going to sign that. So I prefer to do that. But if I will do things well, I will do a good, culturally sensitive translation of what I'm going to do if I want to involve non-English speaking people in the study.
And the communities deserve to hear back from you as well. I can't tell you how many, we get, they want to pick our brains on things, and then the researchers never get back to us.
Yeah.
Or they don't get, and if the research, and they have research, the communities deserve to hear, what they found, thanking them, those kinds of things. So I think that's a really crucial piece to it as well. Did that answer your question?
Yeah.
Thanks.
Oh,
Okay.
thanks so much for